Assalamualaikum and a very good day to everyone. Today we are going to discuss on the trends and epidemiology of non-communicable disease and communicable disease. In this lecture, we try to explain the difference between communicable and non-communicable disease and between acute and chronic disease. We also will try to describe and explain communicable and multi-causation disease model. And finally, we try to explain why NCD or non-communicable disease are a public health concern and provide some examples of important NCD and communicable disease. These lectures are quite long, so we have separated into two parts. The first part, we will discuss non-communicable disease. First, we need to understand what is the difference between them. Now, there's lots of ways how we classify disease. Generally, there are 4 schemes that we can use to classify disease. First is through organ or organ system. And this is what you can find usually in your textbook, like Kimball's or any other clinical textbook. Usually they organize it as an organ or organ system by heart disease, kidney disease, infectious disease, and so on. There's also another classification schemes that classify disease from their causative agents that cause the disease itself, either biological or chemical or is physical. Another classification scheme classify the disease according to the length of the symptom or the manifestations. And this is classified as either acute versus chronic. So if the peak symptoms are less than 3 months, so we classify it as an acute disease. Whereas if it is more than 3 months, we will classify them as chronic disease. Now, finally, the classification of interest now in our lecture is actually between communicable versus non-communicable disease. Non-communicable disease, which is abbreviated in this class and everywhere else as NCD, is a medical condition or disease which by definition is non-infectious and non-transmissible among people. Communicable disease are illness caused by an infectious agents or its toxins that occur through the direct or indirect transmissions of the infectious agent or its product from an infected individual or via an animal, vector, or the inanimate environment to a susceptible animal host. Now let's see how we can classify some of the disease into the classification scheme that we have discussed previously. Now, if you remember, acute versus chronic depends on the length of the symptoms, of the peak symptoms. And communicable versus non-communicable depends on whether it is transmittable to others. Now, disease that you know, perhaps are more familiar, common cold, is a type of communicable disease and acute in nature. Same with cholera, dengue, measles, pertussis, and also typhoid fever. Appendicitis, poisoning, and trauma is non-communicable because you are not able to transmit it to others. But it is an acute disease because the peak symptom is less than 3 months. Tuberculosis, AIDS, Lyme disease, syphilis, rheumatic fever are a type of communicable disease and is also a chronic disease. Whereas diabetes, congestive heart disease, osteoarthritis are non-communicable disease. Chronic non-communicable disease can be defined by a certain characteristics. First, we do not know certainly what caused it. There is uncertain etiology. Second, there can be multiple risk factors for an NCD to happen. So risk factors means that the factors that can increase or decrease the chance of people to be exposed or to contract the disease. So some of the disease, for example, diabetes, there can be many reasons for it. Your lifestyles, your genetic dispositions, the environment that you've been living in, that's caused these multiple risk factors of having it. The third characteristics of a chronic NCD is long latency period. So before they have a symptom, before they know that they have diabetes or hypertension, before they have this headache because of the hypertension, before they have this problem in their frequency, bladder frequency, okay, because of diabetes, they don't know that they have this disease. So it's a long latency period. Okay, so it might be 10 or 15 or 20 years ago, they might already have having this disease, but the symptom only appear much, much later in their life. The fourth characteristic of a chronic NCD is non-contagious origin. They are not communicable. Fifth, they have a prolonged course of illness, more than 3 months. So some of them are known to be a lifetime disease, for example, like diabetes, who until now we don't have any cure for it. 6 characteristics of this chronic NCD that they can cause functional impairment or disability. And finally, it is their nature of incurability. We are unable to cure the chronic NCD. Now, how can epidemiology be used to describe and analyze NCD? So there are various ways that we can actually try to use the descriptive epidemiology to describe the NCD in a country or in a place. First, we can use the vital statistics. We can use the death certificate, which is usually is a legal requirement to in any country to have it before you can actually bring them to the grave or to be cremated. So this death certificate is a reliable and valid method to determine and know how many people have died. And it is also, it can be, and it is complete as well, because you need to have a certain level of authority to complete it. Another sources of descriptive epidemiology for NCD is the health survey. So in the US, they have the CDC, the Center of Disease Control, that conducted survey. And in Malaysia, we actually have this Ministry of Health that conducted NHMS, which is the National Health Morbidity Survey, which can be used to know the prevalence of disease, risk factors, prevention practice, etc., in a country. And it can be an important source of NCD for a country. Another source of descriptive epidemiology for NCD is the disease registry. Some of the disease actually kept a registry, which is actually a list of who have the disease, who already have the disease and receiving a treatment. Okay, so for example, we have cancer registries that recorded who have been diagnosed with the cancer. We have diabetes registries, we have kidney transplant registry, and so on and so on. And this can be used to actually determine how many people actually have NCD and who are they in the country. Another source of NCD data is the administrative data. We can go to the hospital, look at their record, the discharge record, which usually would have document why they have been admitted in the first place. And it can also give not only the reason why it happens, but it can also give us information about the hospitalization rate. Okay, so some of the disease they might require hospitalizations. Okay, some NCDs might not be that severe that require hospitalizations, and we can also determine the cost through this administrative data. We can also have the data source from the special studies, which means that the study was being designed specifically to analyze that epidemiological questions. And for example, Framingham studies, Mayo studies, those are 2 landmark studies that have given us a lot of information about cardiovascular risk factors in the populations. There are other sources of NCD, which is, for example, a notifiable sentinel system, census, which is a population count by subgroups. So we can use that to actually estimate and determine the epidemiology of NCD in the country. So this is examples of how epidemiology used this information. We can see here Murray and Lopez, this was back in 1996, when they tried to determine what is the global burden of disease in the developing regions. And they plot the number of deaths over the years, okay, and compare it between non-communicable disease, communicable disease, and also injuries. And they can see that the trend over the years, over the past 20 years, was that the disease, there is an increasing deaths because of non-communicable disease and also injuries. But there is a marked and steep increase of non-communicable disease beginning in 2010, whereas communicable disease has shown a declining trend in the cause of death in the developing region. So what we see now is that a large number of deaths in the whole world were caused by non-communicable disease. So previously, many years ago, people died because of communicable disease. A lot of people die because they don't have access to antibiotic or clean water or clean infrastructures. But nowadays, since we have solved almost all of these public health concerns, we see that now we have a problem with non-communicable disease, which made up a large majority of in the world. So this is a snapshot of NCD in Malaysia back in 2010. So we can see that the number of deaths because of NCD is actually higher in males compared to female in Malaysia. So if you still remember our discussions about how does epidemiology try to describe a certain disease, okay, so one of the variable that we always look at is the person variable. We want to look at who has it. So we can see male has higher rate compared to female in terms of death, and also almost all the major NCD. Okay? So males actually have a higher death rate compared to female. So, but in terms of behavioral risk factor, okay, we can see that males have about 40 times more than female in terms of their daily tobacco smoking, but female actually have a slightly higher physical inactivity compared to male. So these are informations that actually will be useful for us when we try to actually see how we can prevent NCD from happening. NCD, as we discussed earlier, has been seen to be overriding communicable disease in many developing countries. It contributes 60% of death and 43% of the global of the disease. 79% of this NCD are actually occurring in developing countries. And by 2020, the death actually already accounted for 73% of death actually caused by the NCD. And half of these deaths are attributable to cardiovascular disease. And what is alarming actually, China and India, their populations are very large. There are actually more cardiovascular deaths in both of these countries, China and India, compared to all developed countries added together. So why is it happening? There can be many reasons. Okay. As we know, NCD caused by multiple risk factors. So one of the reasons is the lifestyle change. You can see that there's increasing use in tobacco around the world. Okay. Previously, it was just a manly thing, but now we see that female, largely increasing number of female has been smoking tobacco. And we also now see an alarming increase of school children actually adopting use of tobacco in their daily life. Diets are rapidly changing. There's been reductions in physical activities. There's also increase in the use of alcohol among the populations. And as a result, we can also see that there's an increase of obesity in a large number of populations. Demographic-wise, we see that the populations are aging. Previously, the life expectancy of people, on average, is about 66 years old. But now, in the year of 2000, the life expectancy of the populations are now 70 years old, about 4 or 5 years older, longer than before. We can see that there's increased global influence across the world, and we can also see that the success in public health, the control of communicable disease, sanitation, water, housing, actually contributes to the reduction in communicable disease, but at the same time, contributes to the increase of the non-communicable disease prevention. So, how did the public health respond to this trend? there is now a shift in primary emphasis of public health priorities. So from previously focusing on the microbiology investigations of communicable disease, to now the epidemiology role of behavioral and environmental risk factors and methods. So some of you here who will perhaps be attaching to or be working in a public health department or the clinic kesihatan would found that you actually have to assume this role of public health to make sure that you actually help to reduce the behavior and environmental risk factors to the populations. So we're coming back to this risk factor. What is it? It is an aspect of personality behavior or lifestyle, an environmental exposure, or an inborn or inherited characteristics that is associated with an increased occurrence of disease or other health-related event or conditions at the population level. So we searching for causality in order to design effective public health measure. But we know that it's not easy to find the reason, the cause of NCD, because first of all, there is absence of a known agent. Second is the multifactorial nature of etiology. Third is the long latency period. Fourth is the indefinite onset. And fifth is the differential effect of factors on incidence and cause of disease. So despite this difficulty, we are actually lucky now. We are in 2021, and where there is already a number of studies that have established various risk factors that can contribute to the occurrence of NCD. And this multiple well-designed study managed to actually link up these risk factors with disease, which help us to actually design a strategy to prevent them. For example, here we can see that there's a number of risk factors that can affect multiple NCD. Tobacco, for example, can increase the chance to get the cardiovascular disease and cancer. Diet can affect the risk of having cardiovascular disease, cancer, and diabetes. So as you can see here, some of these factors actually can affect multiple NCDs. So prevention or reducing one of these factors or these factors can actually help us to reduce the prevalence of this disease. So in fact, as you can see here, okay, so this is a study that tried to estimate what is the risk of having the risk factors towards stroke. So what happens here, if we see that there is we can see that high blood pressure have more than 4 times risk, people with high blood pressure have more than 4 times risk to having stroke. Removing this factor from the populations allow us to remove 26% of the incidence of stroke. So more than a quarter of the prevalence, okay, or the people who have stroke in the populations can be prevented if we manage to reduce the number of people who have high blood pressure, which is why in clinic, in a hospital, okay, they usually always try to monitor the blood pressure of the patients going there, so that then they can actually help to prevent this from happening. And finally, this tertiary prevention, where you try to target the symptomatic people who already have the disease, but you try to reduce the complications that they have. What you do in this stage is that you have a proper treatment to them and also rehabilitation, so that then they can keep on improving their functional role, and which leads to a better treatment outcome. So it sounds easy, but what prevents these effective NCD actions to be undertaken? First, there is a myth about NCD, that this is the disease of the rich people, the disease of men, which is why many people, some quarters of people, they actually doesn't want to the government to invest much of this, because they say that this disease only affect those rich people who actually can afford to get a treatment on their own without the help of government. So the government doesn't have need to do anything. So the rich people let them die because of this disease. Second, there is also underestimations of prevention impact. When we look into the health campaign being done, health exhibitions being done, many people, including the authorities themselves, sometimes they underestimate this. They thought that this is just a campaign for political reasons, but this campaign actually allow populations to have an increased awareness of the disease and actually allow us to do the primary preventions more effectively. There is also low public visibility. People see that this disease, because you can't see them, and sometimes it is not very dramatic. So the threat that being perceived from this disease among the populations, they see it as a low threat, and which is why they are not really keen on pushing the agenda or preventing it. So another reason is the lack of direct economic interest. Okay, so there's nothing to sell when we try to prevent NCD. Change in lifestyle, change in diet, for example, it's more like a counseling sessions, a psychological session, when you try to induce people to change the behavior. So there's nothing to sell there. There's no product for us to pitch in. Versus if you have a sophisticated Da Vinci robot equipment, surgical equipment that can do automated surgery, or perhaps a super duper drug that can actually treat everything under the sky. So that is something that people say, wow, this is something cool, something which has economic benefit, and people want to try to invest on it. And government perhaps want to straight away say that we want to have a policy, we want to build up factory to build up this drug, to manufacture this drug in large scale. But there's a muted interest when we talk about having health campaign, having people counseling in your school or in the university. So to try to change the behavior. So there is a lack of direct economic interest in this. So another reasons why effective NCD actions is unable to take off is because of conflicting message, often related to commercial interests. Tobacco smoking, for example, we know that it's clearly affecting a lot, giving a risk to cancer, cardiovascular disease, hematological disease, and many other diseases out there that can be caused by tobacco. But why is it still selling widely in the convenience store? Because of the commercial interest that can be gained from selling it in terms of tax. Inertia in chance. So people doesn't want to inertia in change actually. People doesn't want to change much. So that's why they let this what's been happening to perpetually happens. So how can we actually try to reduce this? To reduce the risk of NCD, the World Health Report back in 2002 has actually already produced a number of suggestions. Mostly through regulatory change. For example, having a higher tax for tobacco, as you can see now, many countries actually implemented what they call a sin tax to tobacco, more than 200% to 300%. Comprehensive advertisement ban in many countries, if not all, they actually ban any advertisement of tobacco. So back in 1980s, I still remember that time. So Dunhill, Lucky Strikes have been sponsoring a lot of these football match. And the advertisement has been on prime TV times and prime billboard. So it was everywhere. But now you can see there is none of it. In fact, on the box of the tobacco, the cigarette itself, it's supposed to be a plain box, and with pictures of the consequence of smoking this tobacco. So this is actually one of the strategies which is being implemented to actually reduce this tobacco use among the populations and consequently the prevalence of NCD. So the World Health Report as well, they recognize that there is a in a populations, you need to make sure that you understand your population well. There are people who have at different stage of this NCD. There are people who are, which means that you need to employ a mix strategies, primary, secondary, and tertiary prevention strategies in your population. And you have to make sure that you do it well so that then you can have a cost-effective balance. And finally, you need to make sure that you have a sustained policy actions to make sure all the strategies that are being implemented is being sustainable. So it's not just one-off. You don't do health campaign one day and then that's it. Then for many decades you just forget about it. So you need to have an everlasting strategy. So health campaigns, so they need to be continuously done in the consistent interval with a consistent message, so that then the message can be driven well into the populations and that it become the norm. So that's it about the non-communicable disease. So we will end the first part of our lecture today, and we will continue next to our part 2, which is non-communicable disease. Thank you and Assalamualaikum.